These are in listen-only mode.
Welcome, everyone. Thank you for joining our webinar with Andrew Penn, RN, MS, NP, APRN-BC. Andrew was trained as an adult nurse practitioner and psychiatric clinical nurse specialist at the University of California, San Francisco. Mr. Penn currently serves as an assistant clinical professor at the UC San Francisco School of Nursing. Also, he is a psychiatric nurse practitioner with Kaiser Permanente in California, where he provides psychopharmacological treatment for adult patients and specializes in the treatment of affective disorders and trauma. He has interest in promoting psychiatric wellness through exercise, meditation, and meaningful social relationships. He is also interested in emerging novel treatments for psychiatric disorders. He has presented nationally and is a past board member of the California chapter of American Psychiatric Nurses Association. Today, Mr. Penn will explore the controversy of using cannabis therapeutically for mood stabilization, anxiety reduction, and the promotion of sleep. He will explain how cannabis works in the brain, what we know about the risk of exacerbating mental illness, how to reduce these risks, and what we still need to learn before we know if cannabis can be therapeutic for bipolar patients. Welcome, Andrew. We're so happy to have you with us today.
Thanks for that introduction, Debbie, and thank you to you and Melissa Lee for inviting me and the International Bipolar Foundation for your interest in this topic, and thank all of you who are out there on your computers for taking some time out of your day to learn about this. So I'm coming to you from Redwood City, California, which is close to San Francisco, and I think it's always appropriate and professional to disclose one's biases before starting a program such as this. One of the things that I run into when people hear that I'm from San Francisco when I present nationally on this topic is they say, "Oh, we know what you're going to talk about because my town is the place where an enterprising Girl Scout once set up a stand for her cookies outside of a medical cannabis dispensary and managed to sell 117 boxes in just 2 hours." But I want to be clear that I have no financial interests in the cannabis industry. I'm not promoting the use of cannabis per se. I want to try and present some scientific evidence of what we have, what scientific evidence we have around cannabis specifically as it relates to bipolar disorder. And I also want to underscore that at my heart, I am a clinician and not a researcher. So I'm leveraging the research that has been done by other people to try and sort of consolidate that information into something that's useful. But I'm not a clinical researcher per se. I spend most of my day treating patients within the Kaiser Permanente system and teach on the side at UCSF and in continuing education conferences. So I have no financial dog in this fight. So it's worth just doing a little review of the history of cannabis, if nothing else because it's a fascinating history. Cannabis has been part of human culture and human medicine for 5,000 years now. There's history going back to China, 2800 BC, that cannabis was used as fiber, as medicine. It became more commonly known as a medicinal substance in the United States in the 19th century, when it was often used in these sort of combination patent medicines like this wild cough syrup here that contained alcohol, cannabis, chloroform, and morphine. I'm sure that probably did ensure a very good night's sleep.
Excuse me.
And interestingly, cannabis became. Yes, can you hear me?
I'm sorry, but we are unable to see your slides. Can you please try and click on the screen sharing button once again?
Oh, sure. Let's try that again. Hold on one second. Thanks for your patience. Has that changed anything for you?
No, not
Let's see.
yet.
Let me go back to my slides. Can you see anything
There we
now?
go. There we go. Absolutely.
Is that working?
So
Okay.
there we go. Thank you very
So, all
much.
right, there we go.
Thank you for your
So
patience.
there's that Girl Scout I spoke about.
There we go.
Can you can you see the Girl Scout?
Yes. Thank you very much.
Okay,
We're on.
we can see the Girl Scout. All right. Okay, so as I was saying, cannabis came into some popularity in the 19th century in the United States as a means actually to help people get off of opiates, which were very commonly used at that time and were creating a lot of problems. In the 20th century, uh, cannabis became vilified through such sort of propaganda films as Reefer Madness, and that's actually where the term marijuana started to be commonly used instead of the botanical term cannabis. Marijuana was used as a sort of a racist strategy to associate the cannabis plant with Mexican immigrants who were commonly being vilified, unfortunately, during the racially charged politics of that time. Um, let's see, let me get my slides to advance. Of course, we all know about cannabis's prominence in the 1960s subcultures, as including some former presidential uh, former presidents that we've had. We went through the 1980s with this sort of backlash to the culture of the 1970s with Just Say No from Nancy Reagan and vilification, prohibition of the drug. I would call this sort of the demonization of cannabis. And then since probably the early 1990s, California had the first medical cannabis law in 1996, with Prop 215. We've kind of gone into this gray area of medical use, and increasingly, which I sometimes call the canonization of cannabis. And then we've gone into this sort of de facto or outright legalization, as we've had in several states, such as Colorado and Washington. And really, the culture has changed to the point where even our current president has admitted that he has used cannabis in the past. We have now 24 states with some degree of legalization or medicalization of cannabis, and there are 5 ballot propositions on the November election, including one in my own state of California for some variation of either legalization or medicalization. So it's very clear that the times have changed, that cannabis is increasingly being seen as being less risky and is being used somewhat more as a result. And we can kind of see where these cultural shifts happened as the lines cross over each other in the mid-1980s with the Just Say No campaign, and then the shift again with Bill Clinton being the first president to admit to having used cannabis, albeit not inhaling, in the early 1990s. And what I'm finding with my patients is that this sort of idea of just saying no to something is really, it's really inadequate. And what my patients want to know, they want to know about the drugs they're using, and I want them to know about the drugs they're using because I'm a big believer in reduction. The idea of harm reduction is that that total abstinence is not always the goal. It's not always patient's goal, and it may not be the goal of treatment, but that any movement towards using less substance, using it later in life, and using it through safer routes is a step in the right direction. I think if harm reduction had a bumper sticker slogan, it would be don't let the perfect be the enemy of the good. So any reduction in use or in the pattern of change in the pattern of use is a step in the right direction. So I'm going to refer back to harm reduction several times in the course of this talk because it's really a guiding philosophy that I use in my daily practice with patients. Let's see here. So a few brief words about cannabis as a plant. Cannabis is there are 2 primary species of cannabis. So the word cannabis is the genus in the scientific taxonomy, and the species, the 2 most common species are sativa and indica. In more sophisticated hybridization growing methods, a lot of times the material from these 2 plants are hybridized to create kind of a combination plant. In general, sativas are considered to be more stimulating and have a more cerebral mental kind of intoxication effect. For some people, they do cause more anxiety and sometimes they are higher in THC and lower in a compound called cannabidiol, which I'll talk about more in a moment, abbreviated CBD. Indica is the species which is generally considered to be more sedating, has more of a sort of a physical intoxicating effect, often is more anxiolytic or reducing in anxiety, can be lower in THC and higher in CBD. Now, most people are familiar with smoking cannabis in the form of a cigarette or a pipe, and the part of the plant which is typically smoked is the unfertilized flower or bud of the plant, which is where there's a structure called trichome, which is where these cannabinoids, the active ingredients in cannabis, are concentrated. There is some in the leaf of the plant, but most of those cannabinoids are concentrated in the bud, particularly THC. Increasingly, in more recent years, there's long been hashish, which is a dry concentration of these cannabinoids, but with more sophisticated production methods, there have been ways of extracting these cannabinoids from the bud with things like butane and other solvents to create such things as what are known as hash oil, shatter, wax. These are all terms that can be used interchangeably, and these are very concentrated forms of cannabinoids. Just to give a little bit of a orientation to measurement, a very common measurement of unit of measurement in cannabis is the 1/8 of an ounce. So these are sort of relative sizes of, obviously this would vary in the density of the plant, but to give some idea of when we're talking about measurements. And when I'm talking with patients, I will often ask them how long it takes them to go through an 1/8 of an ounce, because that gives me sort of a ballpark idea of how much cannabis somebody is using. Cannabis can also be ingested orally, and this is increasingly, particularly in states that have legalized or states that have medicalized cannabis. There are edible versions of this drug that can be ingested orally, and there are even topical salves that can be relief. One of the challenges that I'll talk about a little more in a few minutes with ingested cannabis, there's one issue of unclear labeling, which can lead to somebody taking more than they are taking more than they should. But then there's also the delayed onset with smoking or inhaling cannabis. The onset is usually fairly rapid, and the person will usually somewhat self-limit how much they're taking, depending on the subjective. It can take up to an hour or more before the intoxication effect occurs, and that can sometimes lead to people getting impatient, taking a second dose right about the time that the first dose is starting to come on, and then being surprised by the intensity of the intoxication. So when we talk about cannabis, it's important to be clear that the plant is a carrier for a very complex amalgam of different chemicals. There's over 450 compounds in cannabis, and what most people are familiar with are what are known as phytocannabinoids. So cannabinoids made by the plant. The cannabinoid that most people are familiar with is tetrahydrocannabinol, which is THC, and this is the psychoactive part of the drug. There are about 65 other cannabinoids besides THC. One that is getting increasingly more press is cannabidiol, or CBD. This is a non-psychoactive part of the plant. So by non-psychoactive, I mean it doesn't make you intoxicated, it doesn't it doesn't make you high. And there are others that are less well studied, but there's increasing interest in looking at these for their own therapeutic potential as well. So one of the things that's interesting about cannabis is that our brains, our central nervous system, our bodies are actually have a relationship with this drug. And the parallel that many of you may be familiar with is the opioid system. So as you probably know, we have receptors for opioids in our body. When they're made by our own body, we call them endorphins. And this poses the question of, well, if we have a receptor for cannabis, why is that? What is our bodies, have they been created to use cannabis? And the answer to that is no. But what it turns out is that what's called the endocannabinoid system, the body's own cannabinoid receptors and the cannabinoids that plug into those receptors play an important role in regulating neural activity within the central nervous system. So this is kind of a crude diagram. To the left is two neurons connecting to each other, and as you may know, they don't connect. They don't actually touch each other. There is a gap between them known as a synapse, and that gap is bridged by a release of these neurotransmitters. So to the right is a sort of a crude schematic of a neuron talking to another neuron, and we call this the neuron that's releasing the signal is called the presynaptic neuron, and the neuron that is receiving is called the postsynaptic neuron. So usually a signal comes down the line and it's passed on down by these little neurotransmitters, which have made it symbolized by these green triangles. Now this could be things like serotonin or dopamine or norepinephrine, among others. They plug into receptors on the postsynaptic side, which then sends that, if enough receptors get occupied, that signal then gets passed down the line. So enter in the endocannabinoid system. So you might think of this as an excitatory process. The presynaptic neuron is telling the next neuron down the line, go. Pass this message down the line. You could think of it as sort of like an old-fashioned game of telephone, where one person passes a message to the other person who passes it to another person. With the endocannabinoid system, the receptors are actually on the presynaptic side. So they're on the side that is usually releasing information to the next neuron to pass it down the chain. And the neurotransmitters are actually released from the other side. So this is called retrograde signaling. So these endocannabinoids, the most well-known is something called anandamide, are released by the postsynaptic side, the releasing side, the receiving, typically the receiving side of the neuron. And their job is to go to the neuron that's releasing the neurotransmitters and say, whoa, hold up, hold up. It's kind of like if you've ever helped somebody move and there's a bunch of you and you're all passing boxes down the line and then stacking them in a storage room or something like that, and the person who's doing the stacking is getting a little overwhelmed by how fast the boxes are coming, and that person's says, whoa, whoa, hold on, then you pass that on the chain. This is kind of how endocannabinoids work. So these endocannabinoids send the signal back upstream and say, wait, hold up. And this is exactly also where exogenous or outside the body cannabinoids such as THC have a mechanism of action. So why do we even have this system in our brain? The person who discovered THC, an Israeli scientist named Raphael Mechoulam, discovered THC in 1964. He isolated that from the plant. And he said, you know, it's unlikely that nature would create a compound so a kid in San Francisco could get high. And so when we find these things in the brain, we have to ask ourselves, well, what's the purpose of it? And what it appears that some of the functions of the endocannabinoid system are to regulate things such as relaxation and sleep, appetite regulation, and memory and forgetting. Memory and forgetting is an interesting subject because when you think about it, most of what we encounter in the course of a day, we actually don't need to hold on to. So for example, I can tell you what I had for dinner last night, but if you ask me in 10 days what I had for dinner last night, I won't remember because frankly, it doesn't really matter. So a lot of what goes into our minds, our brains, we don't need to hold on to, but the brain has to figure out what does it hold on to, what does it let go of. and it may be that endocannabinoids play a role in that. Now, if you look at this triad of functions, we can also see that these are exactly some of the same things that people are using cannabis for, possibly therapeutically, and also may point to some of the side effects which are very common with cannabis, such as cognitive problems, which I'll talk about in a few minutes. If you really want to take a deeper dive on this, I really love this website. It's designed for people without a neuroscience background. Has some kind of fun, playful animations that illustrate the mechanism of action of a number of different substances. So if you want to check this out, the web address is on the bottom, or if you just Google mouse party, you'll probably find it pretty easily. So it's important to make the point that cannabis use exists on a continuum. Don't get too hypnotized by that spinning cannabis leaf there, ranging everywhere from no use to a very chaotic, dependent relationship with cannabis. And there are plenty of people who exist somewhere along this continuum, who may use only occasionally, who may use a few times a week, who may use daily, who may use all day long. And it's important for us to think about cannabis use along this continuum rather than thinking of it categorically as something that is either yes or no. We do know that we have a huge problem with overdoses in this country right now. We're facing an epidemic of drug overdoses, and one good news that I can report is that they are not coming from cannabis. They are largely coming from pharmaceutical opiates, and sadly, as we've begun to put limits on and come to our senses about the prescription of opiates in the medical field, we've seen people switching to heroin and to illicitly acquired pharmaceutical opiates, and we've seen an uptick in overdose deaths over the last dozen or so years. Alcohol also accounts for a number of these overdose deaths. Cannabis, fortunately, because there are no receptors in the areas for cannabis in the areas of the brain which control breathing, unlike opiates, an overdose of cannabis might make somebody very intoxicated, but is not necessarily going to result in them dying. Now, let's start talking about some of the risks of cannabis. We definitely know that the earlier somebody starts using cannabis, the more likely they are to develop what we call a cannabis use disorder, which is, in lay language, might be considered a cannabis dependency. So, as you can see from the downward trend in this chart, if somebody starts in early adolescence, they are at a much higher risk of developing ongoing cannabis use. So one of my recurrent messages in this is the longer somebody can wait to use cannabis, the better. Cannabis dependency is more likely to happen, as I mentioned, in younger people, and it's about half the rate for people who start as adults. It's about the same use. About 9% of people who begin to use as adults will develop a dependency upon the drug. So about 1 in 10. That is a similar rate to those who begin to use alcohol. So people who begin to use alcohol, about 1 in 10 people will develop a problem with that particular drug. So again, waiting to use this drug is really in everyone's best interest. Another area of concern is there a cognitive risk in using cannabis? And there are some large, what are called cohort studies, where a big chunk of people are followed from early in life until later in life, and they're measured along the way on different measures of things like intelligence, mental illness markers, and substance use. There's a group out of New Zealand, in the town of Dunedin, New Zealand. It's been followed for, I believe, over 40 years now. And there's been an association found that young people who began using cannabis heavily in adolescence were found to have a loss of IQ of about 6 points when they were retested, again at 38. There was some drop in intelligence quotient scores in people who began using cannabis as adults, but it was not as significant as those who began using in childhood or adolescence and began using heavily. So again, I think this really underscores the point that the longer somebody waits to begin using cannabis, the less likely it is to be impactful for them. Now, speaking about bipolar specifically, because I'm sure many of you in the audience, pardon me, I'm sure many of you in the audience are interested in this specifically as it relates to bipolar. It's very well established that there's a strong comorbidity, is the term we use in my line of work, between, or correlation, if you will, between substance use and bipolar disorder. About 40% of people with bipolar disorder will have a problem with substances at some point in their life, and about 20% will develop a cannabis use disorder. So cannabis is second really only to alcohol. AUD is alcohol use disorder on this graph here. Second only to alcohol as the most commonly problematically used substance in bipolar populations. And there's also data that indicates that people who develop bipolar disorder will develop it at an earlier age, about 3 years earlier, with ongoing substance abuse. And this was looking at different, not only cannabis, but other substance uses such as alcohol. So particularly in somebody, my advice to somebody who is more vulnerable for developing bipolar disorder, say somebody who has a parent or more than one parent who has bipolar disorder, somebody with a real strong family history, or a sibling with bipolar disorder, I would definitely caution them to stay away from cannabis because of the risk of developing bipolar disorder at an earlier age. Now, if somebody already has bipolar disorder and is using, there is data to suggest that people who continue to use cannabis with their bipolar disorder tend to stay manic and or depressed longer than those who don't use cannabis. I think it's also worth pointing out here that tobacco is also a risk for longer durations of depression and mania. So that middle, just to orient you there, the middle graph there is a depression scale, and the one on the right is a mania scale. So we see this increased risk in people who there's less likely to go into remission from depression and mania if one is using tobacco and cannabis together, and tobacco also creates a risk for longer duration of illness episodes. We know with a related illness, of course, there's this sort of fuzzy territory between schizophrenia and bipolar disorder. Sometimes we call that schizoaffective disorder. When looking at schizophrenia populations, schizophrenia generally begins about 3 years earlier with people that are heavily exposed to cannabis, which is disconcerting, again, practical for people that have a genetic loading for cannabis, for schizophrenia, to definitely avoid the use of cannabis. In a study, again, one of these cohort studies following a group of young men they were recruited anywhere between 1st and 7th grade before they began using cannabis up until the age of 18, that each year of regular cannabis use increased the level of what we call subclinical, so they don't actually meet the diagnostic criteria for a disease such as schizophrenia, but they were showing these symptoms related to those illnesses such as paranoia and auditory hallucinations. So for each year of regular cannabis use, the risk of developing those kind of symptoms increased by about 20%. And for some of these subjects, these symptoms persisted even after they stopped using. Now, one thing that's unclear about this is it that the young men in this study who gravitated towards using cannabis, they had already been showing symptoms of a psychotic illness such as schizophrenia, and then were drawn to cannabis as a result of that, or did the cannabis cause the symptoms that we were seeing? It's difficult to make that clarification sometimes. The direction of causation or direction of correlation is difficult to establish. I often get asked if there are genetic markers that might predispose somebody to greater risk of developing a psychotic illness if exposed to cannabis. There are a couple of targets, genetic targets. The one called COMT. This codes for an enzyme that breaks down things like dopamine. And if you're a carrier of one particular variation of this gene, there's a correlation between developing psychotic symptoms at a younger age if exposed to cannabis. A different gene, one called AKT1, this is a gene which, if present in a certain way, what's called an allele, tends to predict for somebody developing paranoid symptoms when using cannabis. Now, for some people, paranoid symptoms create a kind of a self-limitation with cannabis use. So if you become paranoid, a lot of times people don't want to continue using, and that's probably a good thing, because if you are a carrier of this gene and use cannabis daily, heavily and daily, there was a 7 times higher risk of developing a psychotic disorder with that kind of use pattern. So my take-home message in this is, if you get paranoid when you use cannabis, don't use it. It's probably not a good thing for you. Now, this question of, does cannabis make you lazy? Does it make you what we call avolitional? This is an area of research that's really kind of lively right now. There are some people that say a lot of people who gravitate towards using cannabis are depressed, and people with depression are often lacking in motivation, just as a feature of the depression. And so that it may be that, particularly in adults, that cannabis use is more, let me rephrase that, in adults, the lack of motivation that we see in people with cannabis use may be better accounted for by depression. Some newer research looking at an area of the brain known as the nucleus accumbens, which is the area that lights up when we get rewarded. This is an area, when you're thirsty and you take a tall drink of water, if we could look at your nucleus accumbens, we would see it light up because it's feeling rewarded, it's feeling pleased. One of the things that happens with repeated use of drugs that are intoxicating is that the response that this area of the brain has to the drug becomes less and less. And this is also the area of the brain which we need in order to motivate us towards a reward, and that reward might be being told that you got the job, or being told that you got into the school you wanted to, or being told that, yes, that person will go out on a date with you. If that area of the brain becomes kind of blunted, then it would stand to reason that there might be a decrease in motivation towards these kind of these sort of daily life rewards. So this is really my take-home message for young people, is the longer you can wait. I saw an article, it was referring to psychosis, and it said, smoke all the pot you want, but wait until you're 30. And I recognize this is difficult because the average age of starting cannabis use in the United States is about 17. So we really could do a better job with educating our young people to hold off until they're at least into their mid-20s. Now, I know a lot of my patients use cannabis for treatment of anxiety, and this is the association, orange lines being bipolar populations. Anxiety, as many of you in my audience know, is a very common co-traveler with bipolar disorder, and it makes people might use cannabis to try and palliate that. It's interesting to look at this in young people because, so this is an interesting piece of data. About 30% of people who qualified for a cannabis use disorder, which means that they use it regularly, also had social anxiety disorder. But interestingly, over 4/5 of those people reported that they had the social anxiety disorder before they started to use cannabis. And I think this is really important to look at this so that the cannabis did not, the cannabis, the social anxiety predated the cannabis use. So what this tells me is if you're a socially anxious young person, and many, frankly, many of us were when we were young, that cannabis might be a very attractive way of dealing with that anxiety. But the problem with social anxiety and avoiding the things that make us anxious is that we never develop mastery over them. So it's normal to be anxious when we're young. There's many things that we haven't done. We've never gotten a job, we've never asked somebody out for a date, etc. And if we, every time we feel the anxiety of, for the anxiety generated by having to do one of those things, we use cannabis to deal with that anxiety, and then we don't go and do the thing that is making us anxious, we never get the opportunity to really master that skill. And I think this is sometimes where some people refer to it as sort of an emotional stuntedness. I find that somewhat of a pejorative term, but this aversion to taking risks socially that I sometimes see in my young adult cannabis-using patients. Now, cannabis as medicine is a very thorny subject, and I'll tell you right now, this is the sort of how this is set up. We have we are way behind as a scientific community in understanding the benefits of cannabis. And what that means is we have a lot of user reports, a lot of anecdotal data, which is usually considered a fairly low quality because it's not controlled for things like bias. There's a lot of people who have found benefit in cannabis and are convinced that it's working for them, and they may well be right. But the problem right now is, as clinicians, we don't have a lot of scientific data to guide us, and this is in part because we have this very convoluted system as to how cannabis gets approved for clinical studies in the United States. And I'm not going to belabor this too much, but there are a lot of barriers that exist to doing research around cannabis as a therapeutic drug that don't exist for other pharmaceutical drugs. And some of these restrictions have been lifted in recent months by the Obama administration, but the biggest restriction is that cannabis remains a Schedule 1, the DEA, Drug Enforcement Administration, considers a Schedule 1 drug, which by definition is a drug that has a high potential for abuse and a low and no therapeutic benefit. So it becomes challenging to try and study it as a therapeutic drug because by definition it doesn't have any therapeutic basis as far as the federal government is concerned. And that's a real problem for getting good data. So what has come out of this is that we have a lot of states that have medical cannabis laws. This is an ad from one in my state. And as you can see, it's sort of listed as this sort of panacea for all sorts of conditions. And very few of these conditions we actually have data for that it helps. Now, you'll have lots of anecdotal data, and some of it, again, may be absolutely true, but we don't have good scientific data to guide us. Where we do have some data for THC is in these conditions, so nausea and vomiting, multiple sclerosis, neuropathic pain, and anorexia, loss of appetite, and weight loss in conditions like cancer and AIDS. From a psychiatric standpoint, the compound that I'm most interested in is cannabidiol. There is some preliminary data that shows that this is helpful in things like anxiety and may actually even be an antipsychotic. This was a comparison to a drug called amisulpride, which is an antipsychotic that is generally that is not approved in the United States, but used widely in other parts of the world, comparing a high dose of cannabidiol, much more than you could really get from any kind of smoked plant matter. This is really purified cannabidiol, comparing it to amisulpride and finding it equally effective as an antipsychotic, which I think is a very tantalizing result. A lot of my patients use cannabis for sleep, and particularly cannabis indica. Again, we don't have great data on this. I have plenty of anecdotal data that anecdotal evidence that would say that it's helpful. One finding that is certainly makes sense to me is if somebody has chronic pain and their pain is reduced by the cannabis use, then their sleep quality is generally better. But we don't have a lot of good data that cannabis actually helps sleep, but I certainly have a lot of anecdotal data from my patients that it does. There are some studies looking at various psychiatric conditions and cannabis. Again, they're difficult to do because of all the federal restrictions. This is one that if you're interested in looking at, you can go to clinicaltrials.gov. This is regarding PTSD and inhaled cannabis. Clinicaltrials.gov is a clearinghouse for ongoing clinical trials. You all should know about it. It's a great website. It's very searchable. There's a Google-style text box, and there you can type in something like bipolar and cannabis and your geographic location and see what comes up. So for people who are already using, I'm kind of getting in the home stretch here, I want to leave some time for questions. These are the kind of places where I look to reduce harm. Let me go through some of these briefly. If you are already using, one of the things that I'm interested in with my patients is I want to understand the pattern of how somebody uses. And so I might ask them to keep a checklist like this and just put a check in a box when you use. And we'll see if there's any kind of pattern. In this particular example I've made here, this is clearly somebody who's using a lot in the evening and doesn't use very much during the day except on weekends. So with somebody like this, I might say, hey, can we figure out a way to help you with your sleep if the cannabis is creating side effects that they're not pleased with. And there are also some apps, such as this one called Joint Effort that comes out of Australia to help people track their cannabis use. I also ask that people become conscious of how much they're using to actually get a scale and weigh out how much they're actually using to get a real measured sense, and to also begin to read labels. We're all familiar with the labels on food. In states that have medical or recreational cannabis, there are often labels that break down the amount of different compounds, such as THC. There is some question as to how trustworthy these labels are. There's not a lot of standardization in this industry, and plants, by definition, tend to be somewhat inconsistent. So if the bud is on the top of the plant, it may have more THC than a bud that's on the bottom of the plant, and there's some data that's found that these labels may actually be over-reporting the amount of THC in the product. I caution my patients to be very careful with highly concentrated cannabinoids, these hash oils or shatter or wax. The higher the THC content, the more likely they are to cause psychotic-like symptoms. And also, I really advise people to stay away from synthetic cannabinoids, which are known as spice or K2, because these, while they mimic THC, they often bind to that cannabinoid receptor much more tightly than THC and can cause a lot of psychotic-like symptoms. If somebody is eating, to be careful with how much they eat and to go slowly and to have a sense of the dose. Again, labeling is helpful. And if they're smoking, to try and use a vaporized method instead of actually smoking, which spares the lungs the hot combustion products that come from smoking cannabis. With patients who are using, I try and find ways that they can reduce their use. For example, using cannabis only after the kids have gone to bed or after work so that they're not plagued with side effects of things like cognitive problems. If they are in a state that does have some kind of medicalization, legalization of cannabis to get legitimate sources so that they're not exposing themselves to the potential harm of legal action, and to use products with lower THC and higher CBD, and of course not to drive, and especially not to combine with alcohol, because that really does present some risks. And I'm really not here to say whether somebody's cannabis use is appropriate or not. I think that really depends on each individual person. I really would caution young people under the age of 25 to try and stay away from it for as long as possible. But really, this is a conversation to have with individual clinicians and with the people around you to take a look and see what kind of side effects and benefits they may see from somebody's cannabis use, and then to really have a thoughtful conversation with your providers, with the people, with your loved ones about cannabis use. So with that, I'm going to go ahead and open up to questions. Thanks for letting me go a little bit over here. I know we started a few minutes late. But I think Debbie's going to moderate questions, and I'll do my best to answer them.
Great. Thank you very much for your presentation. We do have a few questions coming in. The first simple question is, what does couch lock mean?
Couch lock is that's a term that I'm not sure where I got. That might have been from one of my patients, where you just you don't want to get up. You want to just lie on the couch and watch TV or play video games and really not do anything. It's sort of a slang term for sedation.
Great, thank you. The next question is the harmful effect data for daily use or for occasional use as well?
So the harmful effects, particularly the studies around psychosis, there's a clear uptick in people in the risk of harm for people who use it daily and use it heavily daily. Different studies have defined the term heavily, but really another opportunity for harm reduction is to move from daily use to what's more would be considered more occasional use. So once or twice a week, for example. And really, it seems like daily um, perturbing the endocannabinoid system on a daily basis, particularly during that window of development of the adolescent and young adult brain, is probably not good for the brain, particularly in somebody who is predisposed to mental illness genetically.
Excellent, thank you. The next question, I'm curious as to what the relationship is between adverse childhood experiences or trauma and cannabis use and mental health diagnosis.
Well, that's a great question. It sounds like the writer is referring to the Adverse Childhood Experiences study, which is a landmark study that came out of Kaiser a number of years ago, looking at the kind of load of adverse childhood experiences, such as being sexually or physically abused, not having a parent present, etc., and the higher the number of those kind of adverse experiences somebody had, the more likely they were to go on to develop not only mental health problems, but physical health problems such as heart disease. I'm not well versed in the correlation between adverse childhood experiences and cannabis use. I would not be surprised if there is a positive correlation between the two, but I don't have that data at my fingertips. But it's a great question. I'll have to check it out.
Great, thank you. The next question is, if someone doesn't have a doctor to ask because they can't afford, et cetera, advice, do you have any recommendations, or you again refer back to finding a personal clinician?
Um, if somebody doesn't have a clinician to work with, is that the
Right,
question?
correct.
Yeah, I mean, it's sort of a two-part problem because we have a shortage of psychiatric providers in this country, and I would say we have a shortage of psychiatric providers who are sophisticated in this subject. Unfortunately, there's still a residua of a lot of anti-drug propaganda that really lacked a lot of nuance and sophistication, and so there are a lot of providers who have a very kind of all or nothing approach to the use of cannabis, which is unfortunate because I think what that tends to do is to make people be secretive about their cannabis use or even feel ashamed of it, and it doesn't allow for the patient, if you allow me to use that term, to really have a full conversation with that clinician. And so it's sort of a two-part problem. One is finding a clinician that you can work with and afford, and the other is finding a clinician that you feel comfortable talking about your cannabis use with. And I think it's okay to ask straight up a clinician, tell me your feelings about cannabis. I want to understand. I'd like to know that about you. I think that's a fair question to ask when you're interviewing a provider. I want to go back and tack on an answer to the question about adverse childhood experiences. One thing that I have seen clinically is that sometimes some of my patients who are using a lot of cannabis, more than you might consider to be recreational, and by that I would mean they're using cannabis from the start of the day to the end of the day. I mean, that to me is a red flag that somebody is trying to treat something with cannabis. Most people don't need to be intoxicated all day long. if somebody needs to be under the influence of cannabis all day long, I start to wonder, what are they actually trying to treat with that? And it's not uncommon that what I find is that somebody is dealing with a lot of trauma, and that they're trying to manage their fluctuating anxiety and hypervigilance, and related distress to that trauma by using cannabis. So that to me is sometimes a red flag that there may be some trauma going on. And I often sometimes find, before people are diagnosed with a bipolar disorder, that people who are using large amounts of cannabis are sometimes trying to manage some of the energy and mood fluctuations that accompany bipolar disorder.
Great, thank you for that answer. The next question is, any suggestions as to how to quit using cannabis?
Yeah, so we're not very good as clinicians at helping people get off of cannabis, because for a long time it was thought not to be physiologically I'm not a big fan of the word addiction, but it didn't create a physiologic dependency. And the reality is that it does. Now, the withdrawal is not as dramatic as it is from some other substances, say alcohol or opiates. But a lot of people, when they go to stop using cannabis, will experience things such as insomnia, loss of appetite, agitation, irritability. So one way of approaching this is to try and taper, to use increasingly lower THC containing compounds. There has been a little bit of study looking at a over-the-counter supplement called N-acetylcysteine, often abbreviated NAC or NAC. This is an amino acid that can be bought over the counter, that in a couple of studies has been found to help, this is in younger people and teenagers going through a substance abuse treatment program, were able to go longer without using cannabis when taking 1,200 milligrams twice a day of NAC, which is generally pretty well tolerated, and I'll use this strategy with my patients sometimes. There's been a few small trials looking at gabapentin and topiramate or Topamax as ways of helping people reduce cannabis use. Kind of mixed data as to how helpful it is. In the future, there may be a product available that's actually an oral spray. It's a combination of cannabidiol, 1 part cannabidiol and 1 part THC. It goes by the brand name of Sativex. It's not approved in the United States yet, but is used in Europe and in Canada to help with the pain and spasticity that people get with multiple sclerosis. And I think it might be a useful tool to use what we call off-label to help people reduce cannabis. And there's been, or to taper off of cannabis in much the same way we might use a drug like Librium to help somebody detox from regular alcohol use. So I think there's some interesting things on the horizon that are not available yet in the United States, but might be in the not too distant future.
Great, thank you. Also, what type of approach would you use to encourage young people to get off of the cannabis or reduce their intake?
Well, yeah, especially living in California, which is a state that's had medical marijuana for years now, this idea of cannabis as medicine is a very common one. And so, so if somebody comes to me and says, I use cannabis medicinally, the first thing I want to know is, well, what are you treating with it? And I'll explore that with them. Don't make any judgment on whether or not that's a good or a bad idea. What I really want to do is I want to understand it. And so I'll start by asking questions like, well, tell me about how it helps you. And then later in the conversation, I might have a conversation about what are the side effects that you notice? Because, if we're talking about this as medicine, all medicines have side effects. There's no medicine in the world that doesn't have side effects. And if we're talking about cannabis as a medicine, that includes cannabis. And, if we're having that kind of candid conversation, sometimes people will say, I notice that I'm not as sharp in school, or I'm forgetting things. And then that gives me an opportunity to start talking about where might you start reducing your use. And are there places where you could perhaps use less, or if somebody really is a sophisticated consumer of cannabis and is using a dispensary and has access to lower THC products, could you use a lower THC product in these situations where your cognition needs to be preserved, to really try and start reducing it. If somebody's really ready to is sort of on the cusp about maybe stopping, I might suggest, hey, why don't you do a sober month or two? Just take a couple months off from the drug, and let's take that information that you gain from that and compare it to how you're doing now, and see if there's any benefit, and see if also any kind of symptoms emerge that were kind of quieted down by cannabis, and maybe that gives us targets for treating them differently. There might be medications that are more useful more effective for treating that symptom that perhaps don't have the same side effect burden. And ultimately, the reason I use that scale graphic in my last slide is because ultimately everyone needs to make a decision for themselves of how much benefit are they getting from whatever substance it is, whether it's cannabis or lithium or Depakote, it doesn't matter. The benefit has to outweigh the costs. And the costs are side effects and the stigma of taking the drug and having to go to the lab and having to go to the pharmacy. That's all on the cost side. So as a clinician, it's really on me to find something that works, that has more benefit than costs. And that's always a conversation to have with patients. And I really believe in a very conversational approach to providing mental health care.
Great, thank you. Do you have any information around using sleep aids with cannabis to help with sleep issues?
So I'm assuming by sleep aids they're talking about prescription sleep medications. I'm sorry, could you repeat that?
Yes, prescription or over-the-counter sleep aids.
Yeah, there isn't any good studies about this that I'm aware of. Anecdotally, I'm just thinking of a patient I was talking to yesterday who said, if he takes clonazepam and has some cannabis, he sleeps very soundly. So I would suspect particularly the more sedating strains of cannabis, the indica type strains, which tend to have more of that sedating effect, are going to have an additive effect with any prescription sleep medications. Anytime you start combining drugs together, you can get into sort of unpredictable effects. So I think caution is definitely warranted. And I would say the same thing about legal substances such as alcohol. I mean, honestly, I'd be far more concerned about somebody coming in and saying that they were taking Ambien with a big glass of wine. That would actually worry me a lot more, because those two together are much more likely to be really dangerous. But that said, I don't want to. I'm not endorsing the use of a sleep aid with cannabis, because we just don't really know about the safety of it.
Great, thank you. The next question. My son had a complete psychotic episode while away at school at 19 years old. He was involuntarily admitted to the hospital and had nothing other than marijuana in his system. He spent 3 days in a psych ward and was diagnosed with bipolar disorder. He is currently on meds and sees psychiatrists regularly. My question is, could this marijuana have caused him to become bipolar or be diagnosed, or was it just the perfect storm?
Yeah, I'm really sorry to hear about your son. We'll never know, honestly, and I'm not really sure how much benefit anybody gets from kind of doing that, backing with an onset of mental illness. That is exactly the age at which most people develop either bipolar or schizophrenia, and so we'll never know, because there isn't it's not like a clinical trial where there's a control group where there's an exact replica of your son who didn't have the same cannabis exposure. I think really at this point what's probably more important is just moving forward and getting your son good care. And at this point, if he were my patient, I would strongly advise him to stay away from cannabis because of this. He's already had this experience of having a psychiatric episode after using cannabis. So from a standpoint of safety and caution, I would definitely advise him to steer clear of it. Are you still there, Debbie?
Yes, can you hear me now?
Mm-hmm.
Okay.
Yeah, I can hear you.
Okay. Next question is, have you personally seen any clinical improvement of a psychiatric condition in a patient from cannabis use?
I've seen improvement of symptoms, I think, and limited symptoms. I would say that the probably the symptoms I've probably seen with the most improvement are sleep with cannabis use. Occasionally with patients that are having real problems with weight loss, I've seen some improvement in being able to maintain weight with cannabis. With regards to more, sort of other common psychiatric symptoms such as depression and anxiety and mood instability. I mean, honestly, with my bipolar patients who are having a lot of problems with mood and energy and stability, it would be one of the areas that I would say, this is something we can look at. This is a modifiable um, part of your condition. I mean, we can't control for your genetics, we can't control for your biology, but your cannabis use is something that we can modify. And so, again, I'm interested in information. I'm interested in data. So if somebody is willing to say, you know what, I'll take 6 months off and let's see how it goes, and we'll keep everything else the same. We keep medications the same, and they come in and they say, I feel a lot worse since I stopped using cannabis. I first of all would want to know what do they mean by worse. That by that might mean they're more anxious. They might have more insomnia, and those are targetable areas of treatment. And I say, let's do a better job of treating your insomnia. Let's do a better job of treating your anxiety. Um, but it's a difficult question to answer. So I think I have seen some sort of palliative benefits of cannabis use in some of my patients, but certainly not enough that I can enthusiastically recommend it for anybody, because I think for a lot of people, the side effect burden is a lot higher than the benefit. And frankly, I would say the same thing about a lot of our pharmaceutical drugs. So, again, my bias that I disclosed at the beginning of it is that I don't have any financial interest in the um, cannabis industry. I also don't have any financial interest in the pharmaceutical industry. So I have some, I also have some skepticism about the drugs that we prescribe conventionally for bipolar disorder. Some are great, like lithium. I think lithium's a great drug. I think lamotrigine's a really great drug. Some are not so great. And I'm sure anybody who's in this audience who's taken some of those probably has a list of both good and bad drugs for them, and their good and bad drugs might not be the same as the person sitting next to them. So um, again, in individualized medicine, I think what we really need to do is, as clinicians, is work with patients to find what works for them. And in order to have that conversation, we need to create an environment where our patients feel comfortable being totally forthright about their substance use.
Great, thank you. The next question, for young for young regular or occasional users under 30, if they quit now, are there benefits for quitting now in that gap time, or has the damage already been done?
Hmm. That's a good question. I don't really know if it's been studied. If you look in those cohort studies, like the one out of New Zealand, uh, the way that they measured that is that they would check in with these folks every 3 years or so, and one of the measures was a measure of use. And so for people that had fewer incidences of, so they were actually diagnosing for what they used to call cannabis dependency, is now called cannabis use disorder in DSM-5, but people that had repeated diagnoses of cannabis dependence were more likely to show those declines in IQ score compared to those who had uh, fewer points in time where they met criteria for that diagnosis. So I think I wouldn't say that the damage has been done. I think one of the central tenets of harm reduction is it's never too late to quit. So if somebody wants to stop using, even if they've used for a while, I would be all for it. I don't think I would ever say, well, the damage has been done, so you might as well just keep using. I think anytime somebody wants to reduce their use or stop, I'm all in favor of that.
Great, thank you. The next question, is there an alternative for dealing with social anxiety other than cannabis?
Sure. I think the best and most long-lasting treatment is to gradually do the thing that's frightening. And I know most of my patients with anxiety disorders, when I bring this up, they look at me kind of sideways and say, "You've got to be kidding." And I'm not talking about somebody who's socially anxious should suddenly, oh, I don't know, get on a webinar with a few hundred people. And although I have to say this is a lot easier to be sitting, staring out my window of my office and talking to my computer than it is talking to 500 people in a conference hall. That makes my social anxiety a lot easier. But to gradually do the things that make them anxious, I really think is the best treatment. And working with a good therapist who is familiar with this idea of exposure therapy, to create a sort of hierarchy of fears, and start with the easiest stuff first and get some mastery over little things, like it might be something as simple as being okay with raising your hand in class. And you start by doing that in the class that has the nicest people with the nicest teacher, where you're most comfortable, and then you move up to the class that maybe isn't quite so friendly, and so on and so on. But just gradually gaining that sense of mastery of like, yeah, I'm scared, but I can do this. I think that's really the core thing that we need, that we all need to get as we grow and develop in adolescence. I think that's sort of the central task of being a young person, is getting a sense that, yeah, this is scary, this adult stuff, but I can do it. I've done it before, and I can do it again. And there are medications that help somewhat with social anxiety. Some of the serotonin reuptake inhibitors have some benefit in social anxiety, but really, I think there's no substitute for actually going out and doing the thing that frightens us. And we all have anxiety; it's just part of being human. But how we want to handle it is important.
Great, thank you. The next question, I use cannabis to counteract mania feelings. Does this increase depression?
Um, it's hard for me to know without knowing the person more closely. I would ask them to. I think for a lot of people, mania, particularly early mania, takes the form of anxiety. Those kind of racing thoughts and inability to sleep can feel very much, not just like anxiety, they are anxiety. And if we think about mania as an increased state of energy, increased thinking and worry is a form of um, is a form of that energy increase that we see in mania. And so I think for some people, they definitely find sort of subjective benefit in using cannabis to uh, kind of curtail the anxiety that they feel in that state. I think what I would ask this person if I was working with them clinically would be, what else do you find when you do that? Somebody might tell me, well, I can then I can sleep. And if I can start sleeping, it kind of dampens down the mania. Whereas if I don't sleep, I'm going to start revving up and getting more manic. Then it might be beneficial in that particular case. I can't speak to that broadly. I'd have to really understand the details of the individual in front of me. If somebody said, yeah, I use it, but then I start getting paranoid, I'd say, is that really the way you want to be treating your mania, with something that makes you paranoid? Might we find it in something that's not going to make you worse? So that's a long answer to a short question, but I hope it helps.
Great, thank you. So many questions. Do you have time for some additional questions, Andrew, or are
I
you?
can do about 10 more. I can do about 10 more minutes of questions, and then I've got to scoot to I'm in my clinic, so I got to go see
Okay,
some patients actually.
absolutely. Thank you so much for extending your time with us. Next question is, can you
I'm,
comment?
I'm, I'm happy there's so much interest.
Yes, very much so. Can you comment on mixing cannabis with Seroquel? Or all
Not specifically.
pharmaceutical questions just you need to answer based on a personal basis. So these we should leave out.
Yeah.
Okay.
I mean, yeah, I mean, I won't be able to comment on specific drugs with cannabis. I mean, I think it's so the conventional wisdom is that psychiatric medications are less effective with when combined with cannabis. Now, you know what? Honestly, we really need data to support that. I don't know if that's true or not. My clinical experience would say that is the case because, particularly with things like psychotic disorders, if somebody is um, is taking, now I don't know why the person is taking Seroquel. Of course, we use that in many different conditions, bipolar psychosis. Sometimes it's used in small quantities just for a sleeping medication. We use it off-label for anxiety. So without knowing, again, more about the person, but if somebody's taking it for a psychotic condition and then they're adding a drug which potentially can increase psychotic symptoms, you're kind of working at cross purposes. And so I think it would depend on why the person is taking Seroquel. And again, I would want to individually explore that person's experience with the combination of those two drugs. I wouldn't be able to say um, I wouldn't be able to say just in general that there's a problem with that, although there may be with that particular person. But in general, I think a lot of times when people are combining cannabis with psychiatric meds, there are times when it makes their condition worse. There may be times anecdotally when it makes them better. I would really love to have some good studies on this to guide me, so I knew more, but those kind of studies are really pretty difficult to do.
Great, thank you for the response to that question. The balance of our questions are related to personal situations with medication and cannabis. So I think we're going to wrap it up here. I just wanted to say thank you for this very engaging and insightful discussion. Very happy to have this webinar take place today and also be recorded and archived on our website for future viewing or sharing with others. So thank you everyone for joining us, and thank you, Mr. Penn, for joining us as well, and have a great day.
Yeah, thank you for taking time out of your day, and I appreciate everyone's interest, and I hope it's been helpful.
Thank you.
All right, take care. Bye now.